because you're on time, we'll go ahead and get started. We're going to start with a video, and it's based on a session that Merck for Mothers, PSI, Population Services International, and World Bank hosted last year, and on a similar topic. So we'll start with that, and then we'll have a more formal introduction when all our friends that are running a little late, as usual, will come.
Solutions to be able to see these bold visions of ending preventable child maternal death require the engagement of the private sector, because it's huge, because it actually reaches out many communities, because there's a tradition of innovation.
There's substantial unmet need for services, especially for family planning and delivery care. This is probably the most accurate and in-depth analysis of the DHS data on use of family planning and maternal health care by sector to date. Our conclusions are really that the private sector has a large role in providing maternal health. In terms of coverage, I think the private sector is clearly substantial in magnitude, and it's well worth making the effort to understand and work with the private sector.
If we support the private sector, they are going to be able to contribute substantially towards reducing maternal mortality in the country.
What is the local healthcare provider market like? What should we be envisioning?
They are your midwife and your doctors, the independent pharmacists, the drug shop sellers that sure could fill your public sector prescription, but also are often embedded in the communities and where we, the public health system, find it difficult to reach.
What women want is human dignity. They want access to healthcare that is quality healthcare that is actually going to make them better, not make them worse.
From a woman's perspective, they're not seeing private public. They're seeing where can I get care. And if you see it from a country ownership perspective, they really aren't seeing that either. They need to get care to their population.
All health systems should be driving towards some shared outcomes, and those relate to access, affordability, and quality. There isn't any sector that has the proven track record to deliver on all of those fronts consistently.
In our developing economies, it has to be a combination of both. You can actually be very, very innovative in the way you engage the private sector.
In terms of the future, we should look at a situation where we leverage the advantages of the public and private sector in the best interest of the women.
So now for that formal introduction, more formal introduction that I promised. Let's go ahead, let's kick off today's event, leveraging the private sector to strengthen maternal health. I wanted to thank you for coming out, especially since this is our second maternal health event this week, and in light of the fact that there were some holidays earlier this week when we needed to put together the other one, just given speaker schedule and scheduling of rooms. So thank you again for coming, if this is your second time in particular. My name is Sandeep Bathala, and I'm the Senior Program Associate with the Maternal Health Initiative here at the Wilson Center. And today's event is brought to you as part of our Advancing Dialogue on Maternal Health series. And through that series, we work to identify challenges and discuss strategies for improving maternal health. Our series is generously supported by the Maternal Health Task Force as well as UNFPA, or United Nations Population Fund. As many of you probably know, the Wilson Center aims to bring the worlds of policy, practice, and academia together. And for the second year in a row, we were voted the top think tank to watch in the US and among the world's top 10 think tanks. And every time I stand up here not sounding like it's a top 10 think tank when I mess that up every time. It's a lot of T's every time. So speaking of watching, I wanted to make a note about today's session. It is being webcasted live. So what that means for you here in the audience is that when we come to the discussion, I'd ask that you use a mic so those tuning in can hear you. And please introduce yourself and affiliation as well. I wanted to mention also that the Twitter handles that we are using today are hashtag MHDialogue, as well as hashtag End Maternal Mortality. The Wi-Fi password is on the wall. If you come often, it is regularly updated. You might need to reload your username if you're having any difficulty. So before I direct your attention to our esteemed speakers, I think they were called a combination of a superstar or something. You got that email right,
That's
Priya?
an email from someone, I think, here. 3 superheroes.
There
but
we go,
didn't dress up like that. I'm very disappointed.
No, the bright orange, that says superhero to me. But before I direct your attention more formally to them, I wanted to mention why we at the Wilson Center were so interested in hosting this discussion. Part of that you saw in the film that we just screened, and that is because we know that there's a large private sector presence in labor and delivery. And we must ensure that women get the quality of care wherever they seek care. And so we're here today to talk about this sector that they're tapping into, so many are tapping into, and really wanting to talk through issues around quality of care as well. So we're going to first hear from Dr. Priya Agarwal. She's the Executive Director of Merck for Mothers, which is part of Merck & Company. Thank you.
Thank you, Sandeep, and thank you to the Wilson Center for actually allowing us to have this discussion today. We personally think there's a huge important role of the local private sector, specifically private maternity providers, in improving maternal health. Merck for Mothers was actually announced in 2011 at the UN General Assembly. So next week we'll be celebrating our 4-year anniversary. We're little babies, but we are entering our second trimester of the initiative. So for those of you who don't know, it's a $500 million 10-year non-commercial commitment by Merck & Company, and it's purely focused on ending preventable maternal mortality. 2 things: quality of care at the time of childbirth and access to family planning. Purely because if you do a strategic exercise in maternal health to figure out where's the greatest ROI, which every company cares about, that's where you get your biggest bang for your buck. Those 2 points in the continuum of care. But it's the reason I joined Merck for Mothers and why I was excited was because when Ken Frazier made the announcement, he said, I want to leverage what makes Merck a successful multinational corporation and see if we bring the best of Merck to a challenge like maternal health, what happens? So I have access to 70,000 employees, 200 subsidiary offices, and all the business and scientific expertise that resides within the company. So we didn't miscarry. The nausea and vomiting has almost stopped, and we're now in 30 countries and have ensured access to over 5 million women with modern, reliable contraceptives or access to care at the time of childbirth. But the local private sector is probably the largest part of our portfolio. And for the last 3 years, with actually many of the partners in this room, have been working on improving quality and affordability of the local private maternity providers. So you may ask, why? Why the local private sector? So Merck for Mothers is a 10-year commitment, right? We're not meant to be here forever. I'd love to say we're going to solve maternal health in 10 years. It might not happen. But because of that, we're absolutely committed to investing in sustainable solutions, or solutions that have the potential to be sustainable. It's an overused word. Most often in a plan, that means we will transfer to government, whether government knows about your project or not. But it can also lead you to market-based solutions. So private providers are one of those market-based solutions. They are healthcare providers, but they're also businesses. The second reason is that it's an incredibly overlooked part of the healthcare system. I've been in public health for a really long time. I've spent all my efforts on strengthening public health systems. But this is despite the fact that half of Africa goes to a private provider for healthcare. And it's much higher in Nigeria and Uganda, where actually the majority of people in low-income quintiles are going to the private sector. In India, 80 to 90% of the country's population, which is large, goes to the private provider. And everyone says, well, that's just urban. Actually, in rural parts of India, 92% of rural household healthcare visits are to a private provider. The Merck-funded London School data showed that on average, and averages don't really work across countries, but across the 57-country DHS analysis, at least 40% of women were going to the private sector for family planning, antenatal, and labor and delivery services. And hot off the press, although I don't think it's actually gone to the press yet, in India, 2014-2015 NSSO survey shows that if you're just looking for the number of deliveries that's happening in the private sector, and these are only the official private providers, 25% of them in the rural areas of women are having deliveries in the private sector, and 48% in the urban. All of this to say, they exist, they're part of the healthcare system, and we felt we really needed to address their quality and affordability. The third reason is if you actually follow a patient pathway in most of these countries, it's actually very rarely unilateral. It's very rarely only public or private for a particular patient pathway. So surely we want to make sure that wherever women seek care, they get good quality care, not just when they're going to the public facilities. The fourth reason is that most health systems are mixed health systems. The US, which is where we're sitting right now, has Medicaid and Medicare. The UK, where everyone thinks the NHS is a government-run public health system, actually our GPs, who are our gatekeepers, are all independently contracted private providers. Most developed nations have mixed health systems. So we really need to work with national governments and others to recognize the role of these private providers and integrate them. Fifth reason is that they can really relieve the burden on particularly the governments that we're interested when it comes to maternal health and decongest the public health system. We need research to make sure that happens, but there is that potential opportunity. And my last reason is they are huge early adopters of innovation. They are a great test bed for things like ensuring efficiency, customer-focused care. They will invest their own dollars into that, which is great because it mitigates the risk for the public health system, which quite frankly can't usually afford to fail or talk about failure. So for us, it wasn't really a question of whether to engage with the local private sector, but it was how. Because there are well-rooted concerns about quality, affordability, regulation, all of the ones that you're probably thinking about right now. But we felt if you need to reach all women, and I think we all believe in equity, we have to work with all those who serve the women. So who are they? Well, number one problem. They are super diverse and incredibly fragmented. There is no one face. This woman and those community health workers, there's independent doctors, nurses, midwives, community health workers like in this picture. There are small rural clinics and really large urban hospitals. Often the providers are public and private. I'm going to show you this in a minute. They're embedded and trusted within their community, and they're clinicians and business people. The thing we're learning through our programs, and many of the partners here can speak to this better than I, is that they actually do care about quality. They don't just care about the hotel services. They know that the link between business and quality is absolutely integral. So most physicians and clinicians will know that if you have more footfall, which is good for your business, and you have better volume, you are safer. If you see one postpartum hemorrhage a year, the next time you see it, you are not going to be good. So that volume and footfall and quality go hand in hand, and these private providers know that. Often, and this is sometimes not captured in evaluations, they are women, especially in Africa. And I have met so many, I could remember them all, Mama Angel, Mama Dorothy. There are people from the program clinics that we're seeing in Uganda. They're female entrepreneurs. If they have a healthy business, and remember, they really care about the girls and women in their society, there is a direct contribution to her health, her family's health. I cannot tell you the number of times when we go and visit them, they're like, oh, so, how have things changed? Because your clinic's looking really good. She's like, well, I want to build it. I want to go up and I want to go behind. I need some loan, but I think I can do that because women repay loans. And I want my children to become doctors. And I was like, good aspiration, but they have aspirations for their family that they didn't have before. And of course, they're great for the community, and the girls that they're serving, it was amazing. And in Tebe, these girls were like, They see her as a role model. I want to be that person. Like, she's doing really well. She provided great care. So we're really helping a community when we're helping these entrepreneurs. However, let's be honest, there are particular challenges for maternal health, and specifically labor and delivery, that we're solving for in our programs with our partners. The first is quality assurance. Quality assurance is a nightmare for labor and delivery. Time is money for private providers. Complex processes they have no tolerance for, and they need different, more efficient, and tailored strategies for training, meeting standards of care, and measuring performance, because you cannot dictate, because they're private providers. But, and let me show you some pictures, and these are all from our programs. Bottom line from our programs is if you align the incentives and you develop tailored strategies, they do engage in quality of care and they deliver better care. I'm just going to give you a couple of examples, if you'll let me, Sandeep, of what I really mean by tailored strategies. So, and I did this in my whole life, you throw these training programs, they're 9 to 5, Monday to Wednesday, you pay the public providers to attend, which they love because they get a good per diem and they're not in their terrible overburdened clinic. And private providers, you may invite, you may not, depending on what the donor funded, and they don't turn up. And the message you take away is they're not interested in quality of care. So our partners, including Japaigo and Pathfinder, ran it differently. They had programs at 8 to 10 p.m., Monday to Friday, so longer, didn't pay them, tried even asking for payment, 100% attendance. Because they care about quality, but they aren't engaged in the usual CME processes. They feel left out, and the TLC matters. The other thing is they're paying their own money for telemedicine use with WHO, World Health Partners, digital innovation with PSI, and they're super interesting community accountability mechanisms. So we're developing something that I nickname Yelp for Health, like getting women to rate the quality of labor and delivery services. The government is somewhat interested in what comes out of that. The private providers are absolutely interested. Where do we rate and what are the women saying? Okay, so that's quality assurance. The other challenge from a labor and delivery perspective is the business side of things. Remember, quality and business go hand in hand. Sustainable business models, it's really hard for labor and delivery. Labor and delivery is an expensive and risky proposition. You need highly trained staff, you need quite developed infrastructure. The commodities are inexpensive, so you're not really making money on those. And one event, just one delivery, can hurt your brand completely. Bottom line, it's hard, but what we're finding with our partners is it's not impossible. If you can align accreditation and third-party payment, plus access to incentives like loans, which, by the way, go back into delivering better services, it is looking possible. I am not going to stand up and say we have solved it, but our partners are working really hard to figure out whether we can have sustainable models around labor and delivery. So in summary, if we really care about ensuring quality of care for all women wherever they seek care, we cannot continue to ignore private providers. From a health system perspective, if we really care about ensuring universal health coverage and not 50 years down the line, then we cannot ignore them because we have a huge shortage of healthcare workers in the public system and we have to leverage the private providers. So we're showing that there are ways to ensure quality and affordability, but we really need governments, other donors, civil society to actually advocate and work on integrating the health systems and strengthening the overall system so no woman is left behind. So I'm really excited about this discussion. I'm looking forward to a rich Q&A and hearing from our partners and the audience. Thank you very much.
Thank you. Priya, I think you brought some very important points up. I know that when I introduced this, I talked about our interest in really wanting to talk about this, given that so many women reach out to the private sector and then around quality of care. But, you know, speaking to quality of care, the points you made around universal health coverage, how that there are mixed systems all over the world, including in our own backyards. But the issue around sustainability, really talking about how you're going about that, whether that's through loans and such, that was really interesting and really neat analogies to pregnancy there as well. So we're next going to hear from Gina Lago Marcino. She's the Chief Operating Officer and Managing Director of Results for Development. And I think she's going to talk to us a little bit about myths and challenges. Yes.
Great. So thanks so much, Priya, for setting that up so well. I'm going to talk a little bit about maternal health markets in general, and then also give 4 examples of programs that I think exemplify both kind of opportunities to improve markets, but also the challenges inherent in it. And I think actually Priya set us up pretty well on a kind of general overview of the health market really beautifully. I just want to underscore a couple of points. She mentioned mixed health systems, and I think it is important to note that basically every health system in the world right now is a mixed health system, which means that they've got some public delivery, some private delivery, and the system really operates as a market, meaning that patients get to choose where they want to go have care. But strong mixed health systems do have a very key role that's played by government in terms of financing care, making sure there's equitable access for all, and also ensuring quality and monitoring quality. So I think we talk about the opportunities on the private side, but we need to note that there is a very, very strong government role to play in creating the enabling environment and shaping the market, which we can talk more about. So the interesting thing is, despite the fact that there's mixed health systems everywhere, this notion of the private sector is still a bit controversial. There's a lot of discussion about how big is the private sector, how much does the poor use it? Is it good? Is it bad? And Priya gave us some good data. I also was looking at a lot of the data this week in preparation for this, and I found actually an interesting forthcoming paper or working paper that's being produced by Karen Greppen at NYU. I don't know if she's the one that's working with you too, but she's analyzed a lot of the DHS data. And what I found that was interesting is it's very, very clear that for child health, for fevers and for diarrhea, in many, many countries around the world, the private sector is used very much. And there's not a big difference between public and between the rich and poor in terms of who uses the private sector for those services. Interestingly, for maternal care, the percentage that use the private sector is lower. In most countries, it's less than 40% of women that are going to the private sector for antenatal care and for deliveries. And it's also weighted toward the wealthy. So wealthier women are more likely, wealthier and urban women are more likely to be using the private sector for maternal care than they are for taking their kids in for those illnesses. Not totally surprising, because maternal care is expensive. So you might be able to spend a few cents to get the ORS and zinc for your kid that has diarrhea, but you might not be able to afford the delivery, which means you're probably likely to deliver at home. Which leads me to the other point, which I think Priya made beautifully. This is a diverse private sector with a lot of different kinds of players. You've got the high-end hospitals that are mainly serving the rich. You've got the traditional birth attendants that are also private providers that are serving the poor mostly in their homes. But then you've got this group of mainly entrepreneurial women that have created their own maternity homes and clinics, which is an exciting, and I think you shared a lot of great points about that sector and the fact that across a lot of countries, that's an important source of care, are those private providers. So let's talk a little bit about the opportunities and challenges. Obviously, the opportunity of this sector is to expand access, offer care that's often closer to people's homes. It's easier to get there for delivery, more personalized care. I thought it was great that you brought up the women's empowerment point. I thought I was going to be the only one that would get that. But I think this is really interesting. These are women entrepreneurs, and I think it's important for us. Many of us in global health don't often always think about all the gender issues, but this is a real opportunity to empower women as leaders in their community by owning their own businesses and being role models for others. There was actually a few of us that did some research last year on the benefits to women's empowerment of private sector health because so many owners of healthcare businesses are women. So I think that's an important point. And then, of course, the point that at least a small slice of the private sector, and I'll talk about a few of those in a moment, is actually innovating, and there's an opportunity to learn from those innovators. But the challenges are really, really big. I don't think we can underestimate the challenges. And I think many of the challenges actually stem from the fact that this group of providers, we saw a lot of pictures in the last presentation, they are fragmented. They are small scale businesses. They're kind of mom and pop shops. It's a cottage industry, essentially, of people who have started their own businesses to provide maternal care. And when you have those small scale fragmented markets, it's really hard to monitor quality. It's hard to purchase from them. Governments who want to have financing systems to purchase from the private sector can't quite figure out how to purchase from thousands of small scale, relatively unsophisticated providers that don't have great management systems, don't have a lot of time to go to a training program, let alone sit down with a government and negotiate a contract. So that fragmentation is a big issue. Also, the issue of high out-of-pocket costs that we talked about before that either can push families into poverty or they just don't get the care. They deliver at home because they can't afford it and there's no hospital nearby. The other issue I just wanted to point out too is reporting of data. I've been working lately a lot on a major new global measurement initiative, and a big challenge has been how do we get data from the private sector? There's just, vital statistics is one issue, but just basic reporting on quality and administrative data is really, really difficult to get. So governments don't have a clear picture of really what's going on in their systems because private providers have a hard time reporting data. So my organization, Results for Development, runs something called the Center for Health Market Innovations. And what we do is we go out there around the world and we look for the most innovative healthcare business models that we can find. And we document them and we research them to try to figure out which ones work the best. And then we work to connect those innovators with resources to scale their model and also to improve their model. And we currently have about 1,400 total programs, but about 300 of them are maternal and child health focused. And if you're interested, you can go online at healthmarketinnovations.org and look at a bunch of programs. My colleague Lane also left out in the lobby a report that was produced in partnership with our colleagues at University of Toronto, which actually summarizes all the maternal and child health programs that we've found and gives some evidence about what we know about whether they work or not. But what I'm going to do right now is just focus on 4 specific programs that I think illustrate some key points about how we can improve health markets. The first program is LifeSpring Hospital. This is it's a fairly well-known program. Probably many of you have heard of it. It was founded about 10 years ago in Hyderabad, India. And it runs now a chain of 12 relatively small 20 to 25 bed hospitals staffed by nurses and midwives. They're focused on quality. It's pretty basic amenities, but they've been able to attract lower income urban population. They've got a lot of great results that they've reported to us, everything ranging from up to, at certain points in time at least, they've had 90% adherence to clinical protocols. They charge 30 to 50% of the market rate, so they're more affordable. They have very high satisfaction among their customers, and they've been proven to be sustainable. They broke even finally in 2012. So this is a model that's doing quite well. Of the models we've identified, it's one of the most scaled, 12 hospitals. But interesting to note, it's still just in one city, and they deliver 6% of the babies in Hyderabad. So interesting, still not huge in terms of how much impact it's having. It's definitely having an impact, but not enormous for a very, very successful model. A second program that I want to mention is Jacaranda Health in Kenya, which has some similarities to LifeSpring. Also a chain of maternity clinics. They've been really, really focused on getting the business model and the clinical model right. They work with Institute for Healthcare Improvement in Boston. They've focused on clinical protocols, a lot of training of nurses and midwives, measurement systems to measure individual clinician outcomes and help them to improve. They also have taken a sort of patient-centered design philosophy and designed their whole process around the patient, including using ICT, information communication technology, to communicate with patients when they're not there. So really, really sort of well thought out model, thought about everything, they're perfecting everything. But they have 2 hospitals. And they've really struggled to scale because that model is very complex and difficult to scale up. Interestingly, in the last couple of years, they've decided to focus their business model instead of on organic growth and building more Jacaranda hospitals to become more of an innovation laboratory. And their theory of change is now to influence other hospitals, other clinics to adopt some of their practices. And they're looking to actually influence not just other private providers, but also public sector providers in Kenya and ultimately beyond. So a third model I want to mention, some of you may have heard, I'm sorry, I skipped. A third model I want to mention is called Bidan Delima, which is a midwife accreditation program in Indonesia. Now, there are about 70,000 midwives in Indonesia, at least there were in 2008, that's the latest data I could find, and about half of them run their own private clinics. And there's very little government engagement with these people running their private practices. So about a decade or so ago, the Indonesian Midwife Association decided they would try to create a program that would improve the quality of those private providers, initially with some funding from USAID, technical support from JPIGO, later some J&J support. They have created a whole program to train and accredit midwives. Now, on the one hand, this was quite exciting because the data that I've seen suggests that they, at least at one point, had accredited 8,000 to 10,000 of these providers. So they really went for the big scale as opposed to just figuring out one clinic. But the data that I've looked at as well suggests that the quality outcomes are mixed and unclear, and I think this is an interesting model in that it illustrates the potential of using something like a professional association that already has linkages to providers in the community and pushing out quality control mechanisms, but also the challenge of doing that at such a big scale and actually making it work and making it achieve outcomes. Finally, I wanted to share a financing model, which some of you may have heard of, Chiranjeevi Yojana, which is a scheme that was introduced in Gujarat over a decade ago. And this model is a public purchasing program that pays for poor women to get deliveries and other maternal services from private providers in the state of Gujarat. Now, this is exciting because it was fairly big scale, lots of women getting coverage initially. In fact, this program got a lot of attention. They won an award in 2006. There were numbers floating around about numbers of women that were now delivering in facilities that used to deliver at home. Lots of excitement. But recent studies have suggested that there have been some challenges that maybe were overlooked before, that are probably illustrative of many of the challenges of trying to purchase from private providers. For example, many of the hospitals that were impaneled were in urban areas and not in poor areas, so women couldn't actually get there for care. And there were issues with providers charging more, so it was supposed to be free, but patients paid. There were issues with quality. The quality didn't actually change before or after the program. So obviously they hadn't focused enough on trying to ensure quality. So there were a lot of issues with Chiranjeevi Yojana, which again illustrate the challenges, both the opportunities and challenges of these kind of large-scale purchasing programs for maternal health. So just close, I think these four examples illustrate four kind of points that are important for us to think about. First, the LifeSpring model really shows you that even one really fantastic organization is kind of only a drop in the bucket. It's not enough. We need to really think through not just how do we find the next big organization, do another challenge fund, do another competition and find the great innovator, but how do we create an enabling environment for lots of organizations to develop? We need more copycats. You would need 5 LifeSpring hospitals in Hyderabad in order to just cover 30% of deliveries there. So we need to figure out, as governments, as donors, as technical partners, what can we do to create better enabling environments so more really good models come out of the woodwork. A second point illustrated by Jacaranda is the challenge of organic growth of really sort of high quality, complex delivery systems. And I think it makes us think about, are there models to actually diffuse practices, the promising practices, rather than just growing an organization? Are there ways to take the things that Jacaranda has figured out how to do and bring them to other hospitals? We've been trying to do a few of those things at our Center for Health Market Innovations, such as bringing together collaboratives of organizations that are working on similar business models, creating learning exchanges where organizations from different countries can get together and learn from each other, and even beginning to work with organizations like Jacaranda to help them find receptor sites for their practices and help them to figure out how they can adapt and adopt those into other delivery organizations. A third point I'd like to make is how important it is to really try to get government purchasing correct. I said at the beginning that strong mixed health systems have strong government purchasing. There are a lot of examples of middle and high income countries that do purchasing at least reasonably well, but we've had a hard time getting it right in lower and middle income countries. I call it the holy grail because strong purchasing mechanisms, whether they're insurance or vouchers or other contracting models, really ensure that everyone can get affordable quality care, and it improves equity. It also provides a steady revenue stream to providers. So this first point I made about the need to create an enabling environment for more players to come into the market, public financing is crucial for that, because once you've got that revenue stream, it's easier for new entrants to the market. And you can serve a broader segment of the market. LifeSpring has to focus on that segment of the market that can afford the $50 delivery, but they miss the people that can't afford that. So with public financing, you can reach further into lower quintiles, lower income quintiles, and it's a way to bring more players into the market. The other thing about public purchasing is it really gives leverage to actually control quality. The minute that the government starts to actually pay for care, private providers have to take notice of quality initiatives because their money could get taken away. Now, there are a lot of ways we can think about how to do quality, but I think in most countries, the linkage between payment and quality programs is clear. So public purchasing really is a platform upon which you can accomplish a lot in mixed health systems. And finally, I think one of the big challenges, if we're really ever going to do public purchasing, one of the big issues is the fragmentation issues, the lots of different midwives, like we saw in the photos earlier. And there's, I think, a growing belief that we need more intermediary organizations to operate kind of in between the government level and the market of private providers. And there's a number of interesting intermediary organizations that already exist, like PSI, many social franchises. The midwives associations are another. I think that the question is, can those intermediaries over time become even more sophisticated and potentially become partners to government payers, so they can actually be fund holders and the ones that actually manage payment to smaller scale providers and create the incentives for quality. So I think the evolution of these intermediaries may be one of the keys to figuring out how to better organize the market and improve quality, but also link to public financing and solve some of the problems that the public purchasers are having when they try to purchase care. So in conclusion, I think it's important for us to think about how to shape markets. There's real opportunities for governments, for donors, for all of us that are working on this technically to think about these opportunities for shaping markets. Thanks.
Thank you, Gina. I really appreciated the comments you made about government's role. I think that's key to our discussion. I mean, I know we're here talking about the private sector, but those aren't independent of each other at all. You also, I really appreciated, I know we talked about myths and challenges that you'd be addressing, but I think your examples of innovative approaches were wonderful as well. So wonderful, in fact, that once we featured one of the projects here. And if you noticed on your way in, we have some event summaries on topics similar to this that we've covered in the past. Last year, we had a session delivering quality antenatal care in low-resource settings, and we had Faith McGuy from Jacaranda Health here. And so, of course, you can access that on our website, too, and watch that whole video if you're interested. We always do have event summaries and then archive videos. So do check it out if you want to hear a little bit more about the one of the examples that she gave, one of the innovations, I should say, not just examples. So our last formal presentation is going to come from Carl Hoffman. He's the president and CEO of Population Services International, or PSI, as we all know, and they do so much work, but he's going to really hone in and talk to us a bit about their work with private providers and around maternal health, and also speak to challenges and solutions that he sees through his work.
Thank you very much, Sandeep. Good afternoon, everybody. And I want to thank Gina for setting things up so nicely for me, and in fact, both of my previous speakers who really illuminated the topic in a very comprehensive way. It
Oh, and
seems
you
like
have to say women's empowerment too, because
Right,
they both
got
do.
I'll say that several times.
Good. I feel empowered.
It seems like we're living in, it's not up to me to empower you. It seems like we're living in this era, right, of disintermediation, the disintermediated economy, the sharing economy, the Airbnb economy. But I love the idea that I don't talk about us as intermediaries as often as I should. And we're proud of that role. Yes, I think we aspire to play an effective role as intermediaries in national health systems to allow governments to more effectively harness the role that the private sector plays, as Priya so effectively pointed out. So PSI is a social marketing and social franchising organization. We've been around for about 45 years. We work in 60 or so countries, 65 countries. We are, I think, actually the world's largest social franchising organization, and work with about 12 to 15,000 providers. I often call them medical entrepreneurs. They are very often women. I don't think we've done a census of them, but every time I've encountered them in the field, virtually everyone I've met or dealt with in different countries has been a woman. They are business people. They are medical practitioners. They are nurses, midwives. They are physicians. They may be pharmacists. As Priya pointed out, there's a lot of diversity in terms of the private sector in the developing world. And they are providing a service and treating patients, and delivering babies, and doing many other things, sometimes well, sometimes not so well. Sometimes with quality and cost effectiveness, sometimes not. Sometimes they are the only option that's available to the women and others who are going to them for care. And so we've looked at our role as social franchisers as working with others, and certainly under the overall guidance of the national health system, to improve the quality and cost effectiveness and impact and equity of the private sector. You know, here's an example from, I think, Zambia, one of our private providers. And what's the tool whereby we use, whereby we sort of aggregate this important part of the national health system? It's that social franchising tool. And let me just key off some of the points that were made by my predecessors to bring aspects of it to light. I mean, we all are consumers of brands. We all are subjected to marketing hundreds of times a day. We know the power of marketing to drive consumer behavior, right? So the idea behind social franchising is to leverage that power of marketing, that consumer insight, and the use of brands and branding to try and address some of the shortcomings of the private sector, particularly in the developing world, with regard to healthcare delivery. By aggregating groups of private sector providers that meet certain standards into a national branded network, in this case, well, I think Safe Plan is actually the product brand, but in Uganda we have examples of Profam. It's a way to drive toward higher quality across a broad spectrum of providers. It's a way to do quality assurance for a concentrated group of people who want to be part of a network. It's a way to deliver certain best practices and products and approaches to, again, a group of people who have self-selected in a way to be part of a network. And what's the value exchange from their perspective? Because it's a little bit different from the franchising that we might see in the fast food industry, or the franchising that's such a big part of developed economies everywhere. It's not Subway, in the sense that they're not, at least not yet, they're not paying to be part of the network. We are going to recruit them. But what they're getting from us is demand creation. They may be getting advertising and promotion. They're getting the effort that we may expend to drive traffic to their facilities. Why? Because we know we're doing quality assurance work. We have confidence in their ability to deliver the quality services that are needed. The whole world of social franchising, we're not the only ones to practice it, are trying to look at this approach through 4 basic prisms: equity, cost effectiveness, impact, and quality. Can we demonstrate that this approach does as well, if not better, than any other approach that's out there with this particular segment? And it's really a work very much in progress. And I think Gina and the Center for Health Market Innovations will probably be studying this, or does study it, and contributes to the way in which we think about how to measure those 4 aspects of the work. But the idea behind social franchising is we ought to be able to show that equity, quality, cost effectiveness, and impact are all better as a function of this particular approach. I was going to talk about the global private sector because I don't think we should forget that when we talk about private sector in health. We have organizations like Pfizer that are innovating around contraceptive delivery technologies, Cyanopress, which is going to be a groundbreaking and really game-changing solution for women in the developing world. That's underway, and we have long experience, we do, with other large, multinational private sector workers in international family planning, Bayer and others, and of course Merck, which through Merck for Mothers and through its commercial activities has, as Priya talked about, been long involved in this work. But really, the focus of our discussion today is more about the indigenous private sector, the national private sector, which, as my colleagues pointed out, and as I've already said, it can be very diverse. This must be from Uganda, although it could be that I'm not sure that we don't use Profam as a franchise name in other countries, so it could be from another country as well. Again, the idea is to bring everybody behind a brand promise that the health consumer understands when they're going to get health care from the private sector. And the approach has been effective, we think, in demonstrating that response to the need for quality and cost effectiveness and so forth. Sustainability was mentioned. Let me say a word about that. It is a huge challenge, financial sustainability of this sort of approach. Our whole premise for the last 40 years, and many other organizations like ours, social marketers, social franchisers, are based on the premise of subsidy, right? Subsidy from taxpayers, all of us, going to support health programs in the global south, and trying to reach poor and vulnerable health consumers, and the recognition that there are cost barriers that are meaningful, and they need to be addressed in some fashion or another, and subsidy has been the way to do that. But that subsidy, the end of that subsidy must be evident to us all, or the decline of that subsidy must be evident to us all. And so there's a very real challenge now about how to transition to a much more cost recoverable and eventually profitable model for this sort of approach. This is not anything strange to the participants in a social franchising network because, as has been pointed out, they're business people. They understand profit and loss. They understand how to manage their business. And if we are going to be effective at maintaining vibrant networks of social franchisees, we better be bringing not just quality assurance, not just demand creation, not just sort of continuing medical education. We better be bringing business skills, accounting, best practices in terms of how to manage small businesses. And frankly, we're having to learn that, and we're having to partner with others in order to do that. They are, as Priya said, great innovators, partly because of necessity. They're scrappy. They're small entrepreneurs. They don't have big balance sheets. They exist by virtue of the fact that they've been clever and creative. And they are, yes, great channels and sources of innovation. But one of the things I think we would all acknowledge when working with providers everywhere, whether in the public sector or the private sector, is that they can also be big barriers to innovation. So as marketers, we've often focused on the end consumer, the health consumer, and that's our social marketing mindset, understanding, we call her Sarah, what her challenges are, what stops her, what are her barriers from taking on more healthy behaviors, how can we break down those barriers? But very often, certainly in terms of maternal care and in family planning context in particular, the provider can be a real barrier to a more wide informed choice. The provider can be a gatekeeper, and not in a very positive sense, about the options that are available to women. So we've also had to unpack our own understanding of how to work with consumers and reframe the provider as the consumer. How can we get the provider to adopt behaviors that we know are going to be more healthy for their business, but also for their consumers, for their clients? How can we get them to embrace longer-acting methods of contraception, for example, which are time sucks, which may lead to greater quality risks, but which we know have a much greater effect and are an underused resource for women around the world, not just in the United States, certainly in the United States as well, as a way to control fertility, or manage fertility. So, I think it's important to look at them also from the perspective of not just the innovation, but the barriers that they represent. Maybe two final words before we open it up for a conversation, I hope. One is around the whole concept of ratings and the Yelp, which is a great idea, and I'm sure it's coming. The managed care organizations here under the Affordable Care Act are very much living in that reality here in the US, right? Satisfaction surveys and so forth, but we should anticipate that even in our very low resource settings. And I think, again, branding can be an important way that providers, when confronted with that need to differentiate themselves, can do so. And we can use branding, we the intermediaries can use branding as a way to uphold quality standards, to enforce quality standards, and to invite people who don't maintain quality standards to leave the network, which is what you have to do as a successful franchisor. Finally, about data, I agree that it's a real challenge. It's a challenge everywhere, right? In our operating environment, where national systems are weak and governments are weak, public institutions are weak. And the private sector may or may not be better than the public sector at maintaining data, but certainly they have less of an interest in doing that for us or others who are asking them for data. It's time consuming. They may not see it as central to their business success. They don't understand why they have to do it. And that's a struggle for us. We may be collecting, as we do in the 25 or 30 countries where we're operating social franchises now, we may be collecting lots of data about franchisees, about patients, about outcomes, and so forth. We're not yet successfully integrating all that data, but we are certainly trying to do that. And the vehicle that we're using is DHIS2. Some of you may be familiar with it. It's a system that is an open source system developed, I think, by the University of Oslo, designed to help national health ministries with their own data collection efforts. But we see it as a great way to use a software that is designed for governments to help leverage the data collection effort in the private sector as well. And again, it has to roll up into national accounts about impact and about outcomes, health outcomes. And it needs to be seen as part of a national program. And we as custodians of health data feel a deep responsibility to do that and make sure we are accountable to the public authorities that are managing the system. So, we're an intermediary. We're proud of the role that we're playing to try and orchestrate the private sector to be more effective in quality, cost effectiveness, equity, and impact, part of an overall national health system. We understand the limits of our approach, and I look forward to having a conversation with all of you about other things that we haven't thought about. Thanks very much.
Cara, I have no doubts that you should be proud of that role. Although it was, when you were talking a bit about reframing providers' behavior, it really made me reflect on an opportunity I had to see some of your programming in India. Years ago, I took a team of volunteers with me, and we were we were in Delhi in a poorer area, and it was street theater around IUDs. And as much as I joked about, you know, women's empowerment before, the one thing I really loved about it is like a Bollywood skit was made. There was singing, and you know, my people love when there's song and dance associated with anything. I mean, I think I could almost come up with the tune in my, you know, sing it, but I'll spare you all. You know, to know that you're working to reframe providers' thoughts around things, knowing reflecting on what I saw there, and knowing how innovative it was to tap into what's really going to resonate with a community, and that's dance and song in Delhi for sure.
Very
and
often, in many places.
Yeah, absolutely. I'm just thinking about my mother in particular. But, you know, I just say that I have no doubt to think that you have nothing but pride to think about when it comes to your work. We are going to open this up for a discussion now, and like I said, please do use a mic. But before we do that, you know, there were some examples of Uganda that were brought up. I know, Priya, you brought up India a few times, and I just did that now too. So maybe we could start with you, by me posing a question to you before we open it up to the larger audience. I know those are two areas where you have programs. And Gina brought up a good point when she talked about countries learning from each other. So I was wondering if you could speak to your programs a bit in those areas, what you're learning within Merck, and then how they're learning from each other too.
Yeah, great questions. 3 of them, I would like to point out. So I'm actually going to start with your last question first, which is peer learning is absolutely critical. There aren't that many people playing in the labor and delivery by private providers space. So I'm going to call them out. It's PSI, Japaigo, Pathfinder, World Health Partners, and Marigold. And absolutely critical is that they're coming together to learn both on the business side what works and what works on the quality. So absolutely critical, and I actually took down that you also have mechanisms for that, so I would like to have a conversation about how we can bring in the jacarandas of the world and start talking about labor and delivery a bit more. I'm actually just going to build off some of the other comments when I talk about our programs. So the whole issue of scale and intermediaries, PSI in Uganda has actually covered 1/3 of the country by covering 42 districts and all the private providers that should deliver labor and delivery. If you're doing 1 delivery a month, you probably should not be a private maternity provider.
Right.
So anyone who fits the criteria has been covered in 1/3 of the area. However, they're not sustainable right now, right, because they're donor funded. So they've got amazing quality of care, and they're doing business skills training, but we haven't figured out the sustainable business model. So it's like, how do we bring those two together? Marigold, on the other hand, which is actually a sister company of LifeSpring, the scale they've got to is immense. Like, we took them from UP, brought them to a completely new state, Rajasthan. They've hit break even in terms of they're self-sustaining from a financial perspective, and now the UP government would be the 6th largest country in the world if it was a country, has just asked them to scale their clinics, including labor and delivery, across the state of UP, which will be funded by the UP government. I don't think Sharad, their CEO, would mind me saying, because I've been frank with him, I would say their quality of care is 6.5 out of 10. Now, what are we going to do about that, right? Because they're also going to open up another 10,000 clinics from their own money across India. Huge potential there. We've got to fix the quality. And so there are 2 mechanisms. You can have intermediaries, so really support Marigold to become stronger from a quality of care perspective, or you can do what Japaigo's doing, is actually working with both FOGSI, so the National Association, and a private third-party payer. And they've managed to, I'm speaking a little ahead of when it's happened, but I've had a positive-looking email to convince both the government of India and this private sector accreditation to incorporate quality of care standards around labor and delivery. Huge, huge amount of work there. Congratulations, and now they're going to be working with each state, because really health is a state issue in India. So that way, Marigold can encourage its providers, and there's going to be thousands of those providers now, and say, if you meet this accreditation, you now get access to the funding of NABH, et cetera, because it comes with third-party payment. Then, in terms of economies of scale, huge point there. World Health Partners and working with Pathfinder, what they do, because they do charge franchisees to join, as does Marigold, they charge a fee. They're like, well, how do we keep them in the program, right? So you get branded and you get all the good stuff and training, and then you're like, okay, see ya, I'm out of here, I don't need you anymore, I don't want to pay the fee, and then the sustainability goes. So what they're doing is they're using economies of scale in terms of products. So you can get wholesale price products that you know are going to be of high quality. It's kind of what McDonald's does. So one of the reasons the franchisees stay within the McDonald's network is they need those like pre-packaged, and unfortunately they are pre-packaged burger recipes and, you know, ingredients and shake stuff. So I really believe that this whole economies of scale is absolutely key. Just a few anecdotes about out-of-pocket expenses. So in India, what we're finding, and I asked the very, very poor women, why are you going to a private provider and paying out of pocket when you get paid to deliver in the public sector? It doesn't make any sense to me when they are so poor. And they look at me and go, that 1,400 rupees that we get through the JSY program, that doesn't cover transport, which, by the way, is multiple to just go and collect my fee, my money. It doesn't cover all the costs that they still have to pay under the table, India calls it leakage, to the public providers, and actually ends up working out what they're paying to their local private provider and what they potentially might get after the paperwork, though India's trying to solve that, from the public provider. The other thing that I heard from all of, and this was bringing them together, so I was like, okay, so we're going to set a price, and that's what Chiranjeevi did, and that's the way, and like, especially the Indians, but also the Ugandans were like, whoa, you got to let the free market reign, and I was like, what are we talking about? They were like, these private providers know their markets better than anyone who can set the price. They are never going to overprice because their business goes out the window, and they are accountable to their very small community. So the woman you saw in there, and actually Mama Angel's in there, I saw what she was doing. I was like, I got 2 adolescents, both had deliveries because they'd both been had sex with 2 truck drivers that had come through. And no, one had had sex with a truck driver and one hadn't, both living in small containers. And one paid almost nothing, and the other one paid like 10 times that. And I was like, what is going on? So this Mama Angel charges whatever she thinks the woman can pay. So then I got them together, which is probably totally unethical. And I said, how do you feel about the fact that you just paid 10 times what your neighbor in a container paid? And she was like, totally makes sense. I have a lorry driver who paid for my delivery. She's super poor and has no one. Totally fine. So these private providers are often held accountable by their own community. So I totally agree that, like, when we talk about intermediaries, we've got to be careful about affordability in the bottom of the pyramid, but actually often they are the best people to set those prices. So we've actually stepped away on sort of forcing them to charge a particular rate because actually it doesn't do justice to who they're serving. And last comment on data. So data is a huge issue. PACE in Uganda and in Kenya are finding one of the things that can work, actually it's a Kenya team, that people hate collecting data for someone else. I'm the same, right? I don't want to collect data as a provider to give to someone else. But if you can get them to collect data that is useful to them, then they have more incentive. And quite frankly, that's the same with NGOs. So we try and make sure with our NGO partners, I'm like, don't give me 5,000 indicators that you think I want. Like, collect the indicators that you want, and then, you know, I have limited time in terms of what I'm reading. If it's useful for you, it's good for the program. So no one actually wants to collect data for someone else. And so that might be one way of ensuring we get better data because it is working with some. I'm going to stop there.
Thank you. I'm going to keep that in mind the next time I have a funder report, too. This is what I want to tell you, and that's it. Folks in the audience, any questions? Or I can certainly start by asking you all if you have questions for each other while I'm looking for a colleague to get a mic. Oh, or we can start there.
Hi, thank you so much for your really interesting presentations. My name's Rebecca Husband. I work with Cardno Emerging Markets, and I direct the USAID Uganda Private Health Support Program. And so just data, yes, it's a major issue for us as well. We're finding it really difficult to get our sites to report, but part of the problem that we're seeing is actually on the public side, the public side, the district level, they just don't want the data. It sometimes skews their results in a positive way, and then they're worried that these providers will not be there the next quarter, the next month, whenever the next reporting schedule requires it. So are there any ideas from your experience on how you work with the public sector to recognize the data and make sure it's part of the system regularly, or if you've had any innovations around that? Thank you.
I'm just going to add to that because it was actually an anecdote I was going to share, and it comes out of the ProFam clinics. They are collecting data, and they went to the district health officer with ProFam standing there, you know, so like the PSI people, and he was like, I'm not collecting it. Like, this isn't my job. Like, I have enough to do with my little books going to the public health facilities, and now you're giving me data from private providers? No way. Like, I just don't want to do that. In Kenya, when we had I think it's got to come from the top. So in Kenya, when we had discussions with the government and they were like, well, you know, do you have any innovations? How are we going to get the data out? It's like, have you actually spoken to your intermediaries and others? Because sometimes it's getting stuck in the pipeline that they're giving their data and people aren't taking it. So actually WHP and Pathfinder in UP, they actually finally had to go to the chief medical officer of those districts and said, we have data. We have data from the public health system and the private health system because they're working on a total market approach. No one is taking our private sector data. And so the CMO was like, oh, wow, there's no mechanisms, right? So I think it's about creating mechanisms and going much higher than the person who's responsible for the data and creating incentives. Like, why should the public sector want that data? Because one of the things we've heard in UP is it could really show us up, right? So it can make our public sector providers look really bad if the private sector data is better. So I'm not sure this can be solved at a lower level because there's a whole load of politics behind even getting that data if they want to share it.
I would agree. I don't have anything to add to that because we experience variations of that, I suppose, in different places. There's a lot of data, but getting people to pay attention to it is another thing.
And maybe that's the intermediaries' advocacy role,
Maybe.
right? It's like not, the intermediaries have got to go, and all of you, including USAID, has to do the advocacy at a much senior level.
Yeah.
The only other thing I would add is I think that data and measurement is another one of these sort of holy grails. I guess since the Pope is coming next week, it's a good analogy. But really, really important and really, really hard to do. I've been working separately on an initiative that's going to be launched at the UNGA and the Primary Healthcare Performance Initiative, not particularly focused on maternal health, but generally on better measurement for primary healthcare. One of the things we've focused on actually is on the need for better service delivery indicators. And interestingly, service delivery indicators tend to be things that are more of interest to the providers themselves. And they're also crucial for governments to understand if they actually want to figure out what to invest in to improve healthcare. So part of the goal of that initiative is to develop new ways of measuring service delivery components like coordination of care and how well providers know clinical protocols, et cetera, so that those can be used in improvement. And they often are things that are more of interest to the people that are actually managing the systems.
I think there's a question towards the back and perhaps on the side too, but we'll do the back first since you're there.
Hi, I'm Insha. I've just moved to the States. I had a 10-year association with Mary Stopes International Pakistan's program, and I'm missing them so much in the room. I've moved on from there, but my 10-year association is not easy to move on from. So I had two questions. And the Pakistan program, the Mary Stopes Pakistan program, is a huge social franchise service delivery component. And just drawing from that, so two questions. One is, of course, the government has a really major role to play in terms of a very strong health system. But what we noticed was the government felt a little competitive. And so have you witnessed something like that in any of your other programs? And do you have any solutions on how to make them feel they're partners? And we know that we did. We had them part of the accreditation team. We had them part of standardizing the quality of care standards, the training modules that we were providing private providers for. All of that was done. But there's this element of, you are taking away my cases, so to speak. So one question is that, and the other question is, so you come across a really nice private provider. She has great potential, she's fantastic, and she'll be able to provide the services that you want her to provide. But you realize that she's not just providing maternal and child health care, she's doing other things also. So what we had actually also successfully did was that we franchised them partially. And so then we would call them partial franchisees. And I was just wondering if any of the panelists or anybody in the room could share similar experiences, and how far does that go in terms of sustainability? Because I know that with the partial franchising, the standards of quality and the concept of quality and the entire notion of client satisfaction kind of seeped its way in other services also. Because once they were aware, so yeah, before I just keep going on.
Sure. I mean, first of all, I very much admire what Mary Stopes. Mary Stopes is our sister organization, and the program in Pakistan is, as you say, very vast and very effective, and I envy it. I think on the question of the government often feeling as though private providers, franchised or not, might be competitors in a sense, I'm sure we can all relate to that. You can, we've experienced it, you see it, you can imagine it quite easily. I think there's actually a bigger or a more pronounced phenomenon, in our experience at least, which is that they're indifferent to what's happening in the private sector. They're too inwardly focused in terms of what's going on in the public sector, which is an equally bad problem, right? We know there are developing country environments where the national health system is capably led and with inspiration and vision, and in those circumstances, and you know, there are a handful of places we can think of with really strong health ministers where they look at the national health infrastructure as something that they are responsible for, public and private, and it's great to work in those environments because they give you guidance and they have their own priorities, and you can agree or disagree, but it's great when there's clarity coming from the top. But it's rare. It's rare. So I think there's the problem of competitiveness, but also indifference. And on the fractional franchising, we absolutely practice that, and it's probably the majority of our franchise relationships would be considered fractional franchising. But I would agree with you in the sense that we'd like to believe that the franchising techniques and the way we're approaching the relationship with the provider bleeds over into the other aspects of their work in favorable ways, in ways that has an impact on quality in terms of the other services that they're providing. Why shouldn't it? And gives them insights into consumer, patient satisfaction that are important to their business outcomes. Why shouldn't it? I mean, I think it works, whether it's a full franchise or a fractional franchise.
Just a point on the government competitiveness. I think that countries that are really pursuing universal health coverage through a sort of health financing mechanisms, which is not all countries, but there are a number out there. Some that I've worked with include Ghana and the Philippines, maybe a little bit to a lesser extent Kenya. I think the people within government that are focused on the financing side tend to be more open to the idea of talking to the private providers, because they need to figure out a way to deliver care, and they're not in charge of the hospitals and the clinics in many countries. But I've actually been struck by, I would think if I were one of those people that the minute I would be like chomping at the bit to talk to Carl about how he's going to provide care for my people. And I served actually as a manager of a program here in DC a number of years ago. And all I did was spend time talking to private clinics in town and private hospitals about how they were going to provide care. But I think there's still a barrier, even among those financing organizations, and I'm not sure exactly where it stems from. I think it's partly lack of understanding, a little bit of mistrust, and also just very different cultures, and also problems. I think there are problems that the financing agencies have that aren't totally solved by, say, the social franchising model. They have a particular package of benefits. They want to be able to deliver all those things. If the provider can only give this slice, then they're not as interested. And they may be more interested in more kind of I guess, authoritarian or stick models of monitoring quality and not quite get some of the private models for ensuring quality. Yeah, peer-to-peer. So I think that there are opportunities, particularly among those financing agencies, but I think there's still work to do to get the dialogue going.
I'm going to make two provocative statements on this. I've heard it from others, but one of the problems is public health people don't talk about the private sector enough. Right? So think about the majority of us in your history. I can talk about my own public health history before from others. I was completely focused on the public sector. And the technocrats in these ministries of health all have very similar backgrounds. So if donors and NGOs and people who are working with the governments don't say, oh, great, you've got this great proposal on this, or to the government, okay, you're doing great on this, what are you going to do about the local private sector, right? So taking the whole total market approach, they're going to continue to be allowed to be indifferent. And they're being indifferent because we're all indifferent, right? And actually, some people just have ideological barriers against the local private sector. So yes, there are some shining lights, but actually a lot of the governments is because it's full of us. And we don't talk about this enough, and we don't hold them accountable to dealing with that side. Julio Frank, previous Minister of Health in Mexico, spoke to me about this really early on in Met for Mothers, where I was like, oh my God, are we really going to be looking at private providers? Like, I'm not sure this is the right thing when everyone is telling us to do this. And he's like, he actually took Mexico on this transition. Decided on universal health coverage. You have to have that sort of mandate that you care about everyone. And he said, when he started looking at it, he was like, wait, this totally doesn't make sense. The government currently is regulating itself, right? So you have your regulation responsibility, which should absolutely be the government. And then in most countries with a colonial background, you're also doing service delivery, right? That needs to be separated. Otherwise, you're governing yourself, which is a huge conflict of interest. So he took them on a journey of, let's allow the private sector to do whatever that may be called, to do more of the service delivery, not all, but more, and let the government really focus on its primary job, which is regulation. And so he did what now we're seeing in some states in India and some other countries, and Kenya's interested, which is some models of outsourcing, right? But there are some ideological barriers, and we're all responsible for asking, what about the women or the community that are going to the private providers? How does this program or your initiative or your principles address those things? On the fractional franchising, my other provocative thing on this is, I don't know how I feel about fractional franchising, because one could say it's morally wrong, right? So when someone from the community comes, it's beautiful hospital, you've only quality assured 3 services. They're going there for 12 services. And we know that it doesn't all bleed over, because PSI was brilliant at family planning in Uganda, and it took 18 months to strengthen the quality assurance for labor and delivery. So I think what our partners are doing is saying, okay, what is the group of services, if you're not just going to do labor and delivery, and some do, what does a community need? And maybe it's 15 services that are like 90% of the appointments you get. Quality assure all of them. It's good for quality and it's good for your business model. And I personally think it's the morally right thing to do, because as a customer, I don't know what you're getting quality assured for, because your building looks really nice to me. So.
Good point.
Very, very quickly. Okay, I think we had a question on the side over here.
Ibukun Ogunbekun, Connect to Health LLC. It's a consulting practice based in Reston, Virginia. I mean, talking about the private sector in developing countries, I think first of all, we need to understand that the sector or the subsector in most countries grew by default. It wasn't by design. The failures of the public sector was what led to the growth of the private sector in healthcare. It wasn't like some minister decided in most of the countries that, you know what, a robust private sector is good for our country. No. It was mostly the public sector believing that it had to lay the policy, It had to provide the infrastructure, do the training, and provide care directly. And of course, monitor itself, which it did so excellently well. So I mean, we always have to have that at the back of our minds, that the private sector grew aggressively and independently, while the public sector was in denial. In many countries, up until very recently, they didn't actually believe that they had a private sector. I come from Nigeria. I worked in Nigeria several times for many years in the public and the private sectors. When we're talking about data, I want to go back to, I want to focus on data specifically. That the national health systems, the national health information systems in many countries were designed for the public system, not for the private sector. I remember when we started discussing the national health information system in Nigeria, and we had a huge conference. This was in 1991. About 100 papers or so were delivered. Only one was on the private sector. That was good. At least somebody recognized that something about the private sector was necessary. But the systems were not designed to include the private sector. Where the public sector has tried to obtain data from the private sector, it's been more of an intent to regulate. And as you rightly identified, first, you cannot regulate what you do not know about. The private sector will not let you know about their business if your primary intent is to regulate us for taxation or for whatever purpose. There's deep mistrust between the public and the private sectors. Secondly, data for planning, for epidemiological and for planning purposes are quite different from data for operational management purposes. Your service delivery data, yes, that's what the private sector provider is interested in, because really, that's what's important to my business. I mean, I talk now as in the place of a private sector provider. I worked with them. I also was at a point providing medical services. You want to get a loan from the bank or from anywhere to build a practice or to improve your service, it's almost impossible. Now I take all the risk, right? And then somebody who hasn't contributed anything to helping my business grow comes around and says he wants to have information on how well my business is doing. I'm not going to give the person any data. And if he insists, I will give him whatever it is he wants. It isn't going to be accurate. Data that are useful to my business as a private sector provider will be my primary concern. Then I can accommodate other things. And I think in working with the private sector, it's very important that we understand where the shoe hurts. They are private business people. They are very welcoming to quality initiatives, very welcoming. They're very welcoming to business management, imparting business management skills. They're interested in improving quality, but we've got to understand the psyche. I have one question.
Okay, one question, because I think
Yeah,
we
I'm
have
sorry,
another one
yes.
over there.
The question I have, working with private sector providers, many times when you talk about sending their staff for training, for continuing education, there tends to be a reluctance on the part of the owners of the business. And it is like, we train them, and then they go elsewhere and work, or go and set up business as our competitors. In your experience, did you see such things happening? How were you able to or how are the providers able to overcome them?
And maybe I'll collect, did I see another hand in this corner over here before they respond to that? I just want to grab that question if so. No? Okay. Response to that.
Maybe just to your question, and probably your neighbor on your right can answer that better than me, but absolutely there's an issue about owners not wanting to send their staff out. However, and I'm going to talk about India as my example there, most of these owners, so if they're not the mum and pop doctors who are running their own services or midwives, they hire nurses that actually can't escape. So they're often not formally accredited. Now, they're incredibly experienced because they've been there for years with these owners, and they're actually doing the services. So Japaigo found when they went in, the plan was to train the people that were allowed to train, which is the formal providers. But actually, they were missing a trick if they didn't train everyone working that facility, because that owner, who's the official formal provider, isn't there. So actually, they got permission to do team training. And the second thing that you have to do is on-site. So when we talk about tailored strategies, this whole taking people over to like Lagos and Nigeria or Abuja for the training isn't going to work, right? So how do you tailor your training so it's actually more appropriate for private providers? But your biggest message, I thought the two important things from what you were saying, and is a huge message for the whole communities, we've got to understand these private providers better. Right? We can't make assumptions on what their needs are and who they are and what are their pain points. We really need to understand why, for example, they're not giving data. And that speaks to your question. That is, Farm Access have found that if they link better data, and not better outcomes, just like better accurate data, to access to loans, which is often the biggest pain point, then they'll give the data. So I missed that as one of the innovations, but I think your biggest point is we've got to do a much better job of understanding who these private providers are and what really are their pain points.
Either of you want to add to that at all? No? I did start to promise, so I don't want to go back on my word. I want to give you guys an opportunity to ask if you have questions of each other. I know that you built well, and if you don't, off of each other, but if you don't have questions, that's fine too, then I have one. Let's go for it. Okay. So we need to wrap up. So I guess my last remaining question is, what's next? What do you think should be next? What's your call to action, especially as we are in September of 2015 in particular? And there's a lot of discussion about what's next now.
Sure. For us, narrowly, so we have social franchising, a long history in social franchising, like my friend from MSI here does. We're very focused on what internally the shorthand for it is social franchising 2.0, which is much more about being cost recoverable, so looking for those elements of financial sustainability. And then social franchising 3.0, which is a more profit-oriented model. There are many out there, of course. We have not tended to work in that space because, again, we've been focused on subsidy. But to be responsible and to continue to grow our work, we think we need to understand that space and move into it where it's appropriate. Because the audience needs are there, the donor funding may not be. We better understand how to get to higher cost recoverability in the way that we're approaching this part of our work. So for us, that's what's next in social franchising.
What about your 2.0, your 3.0?
So this probably won't come as a surprise based on what we've talked about or what I spoke about earlier, but I think that creating mechanisms to get governments working with private, whether they're individual providers or intermediary-like organizations, is a crucial next step. And I think we're at a sort of inflection point where I think there's more recognition by some governments that they need to start doing this. I think there's recognition by a few donors who've worked in the private sector space that the critical next step is to figure out how to do purchasing for sustainability and for shaping of markets into the future so that markets evolve in positive directions and not in negative directions. So that's what I'm the most excited about, is trying to figure out how to get those dialogues going. We had an interesting dialogue in Kenya in July that included, of course, Kenyans, but also Ghanaians and Tanzanians talking about this issue. And there were representatives from both MSI and PSI there really discussing, and representatives from the government purchasing agencies. And we were really trying to think about what are the big issues that we need to get past in order to build stronger relationships between the delivery organizations and the purchasers.
Thank you. So Merck for Mothers, as I said, 10 years. So our $500 million is a drop in the ocean when it comes to global development dollars. So our role is to design, test, and advocate for scale-up and use data for evidence-based advocacy. So as I said, we're in the second trimester. We're really now entering the advocacy space. So you'll see we're going to be talking about the local private sector at multiple events. One is to make sure that the lessons we've learned from our partners, and they continue to learn, get out there, right? So they've got really important lessons that they need to share, both successes and failures. So that's number one, to start talking about this. Two, it's absolutely critical for GINA's enabling environment. We need to start advocating with the donors, with the governments, bring it up. We're going to end up sounding like a broken record, but we've got to keep thinking about it. And then the third is to really understand what are the pain points in this space that private sector, and then I mean us as private sector, should bring what makes Merck earn $1 billion a week to this issue. So one of those that you highlighted was this fragmentation. So when I went back to the Merck people and said, oh, I've got this issue, they were like, we have that issue all the time. I was like, okay, well, then what do you do about it? They're like, simple, market segmentation. Let's bring the market segmentation people in and let's segment the market. It's not actually 100 types of providers in India. There are segments, and then you develop standards and toolkits for those segments. So it's, I think we need to create a safe space for the people who do have lessons, and it's not just about our program partners, it's about who else is working in this space, to say, okay, first of all, what have you learned? What is working? What's not working? And where do you really need help from people who totally understand this space and haven't been part of the conversation? But I'm going to leave you with a call to action, and that's all of you need to become advocates for ensuring that people get the best care wherever they seek care. So if people are not just going to the public sector, you need to start engaging in that. What about the private providers, and what about the local private sector, and whichever organizations you're at? Because unfortunately in the development space, we often drive the agenda. So if we're not accountable and we don't hold others accountable to creating a strong integrated health system, we're failing the women at the end of the day.
Well said.
Thank you. Sounds like you all have a task. Yes, please join me in thanking our speakers, and thank you for being part of this important dialogue, and continue to come to our events and follow us on our website, Facebook, Twitter, wherever else we are. Thank you.
Thank you.
Thank you.